That's a very difficult question. I think I would use the joke frequently quoted. It's coming from Carlo Di Mario and Antonio Colombo. I think Antonio Colombo was more responsible for the joke. He used to say in public, if you want to treat the lesion, do an IVUS. If you want to avoid a treatment, do an FFR. And there is something true in it, in the sense that you are comparing anatomy versus function. Anatomy, you don't know if there are a functional impact, and function, you know that there is an impact. So you understand this joke. Now today, I think you will do an IVUS not only for the grayscale, but for also the composition. And sometimes you have from the non-invasive imaging some hint that you should do it. For instance, if you see on the multi-slide CT scan a lot of remodeling, you know in advance that you will have a very large plaque burden. And then you want to know what do you have on surface of this plaque burden. And you know, you have in some way the people guided by the anatomy and the people guided by the function. When we were working on prospect, we were more relying on anatomy, and at the end of this period of 3 years of observation, we came to the conclusion that some lesions had some prognostic morphological characteristic. So yeah, when we have some indication that there is remodeling, which is a sign of instability and severity because it's a larger plaque burden, we know that in advance. That's indication for IVUS in general in the diagnosis of the lesion.